SI joint fusion. Okay. We're going to accomplish the lateral and posterolateral approaches. Dr. Dave will be covering the posterior approach in the next section. And so this is for patients that have SI joint pain, SI joint dysfunction, which is not defined by imaging. It's defined by the presence of SI pain. And usually these patients, 70% of these patients will be patients that have had an SI, had a lumbosacral junction fusion, L5 to S1 or long segment fusion across to S1, or pelvic instability. Those will be the lion's share of people. These will undergo an injection test, having at least 75% relief of their SI joint pain. And then the other criteria is they have to have 3 out of 6 physical examination test positive for SI pain, pelvic thrust, pelvic compression, sacral thrust, Gainsland's test, Faber's test, thigh thrust test. And it's also nice to have tenderness along the sacral sulcus or a positive Fortin's finger test. And so they've done all this, they've gone through, they have SI joint dysfunction there with you. And so we're going to start out with a lateral approach. And so this is the demonstration of the angle of the sacrum. So I'm going to put this right here, and let's take a picture of that. Okay, so picture again. Good. That's the angle of the sacrum. So I'd like to point out that the angle of the sacrum is superior on the cadaver is this. Superior on the SI joint is this, right? So projecting like that. So inferior on the cadaver is this way. Inferior on the SI joint and the sacrum is this way. So we have to normalize it. So therefore I put marks on here to be able to, can you move toward me and give me a little bit of room here? We put marks on here to be able to find exactly where we are. And so we will start out by putting an implant in S1. So picture this. Good. Picture. So I'm going to go picture in the mid body of S1, picture. And we're going to make an incision right about there. This will be our starting point. And so we always start with rigid access. These are Steinman pins, have some give to them, but I really prefer to start out with rigid access. Okay. All right, picture here. Picture here. So we will find, picture here, the mid-body of S1, picture. And the vestigial disc marks the foramen, picture. That's exactly where we need to be. We'll start off, and this has rigid access, and we'll go in, picture like this. Picture. I can hear I'm right at the SI joint. We hear the tone of the hammer taps change, and I'm sure you can hear that. That way we know we're right at the SI joint and we're relatively going in straight. So let's come back around. And first I'd like to come back around and do the pelvic inlet view, which is looking from the feet up toward the head. The II is looking superior. So we'll come out, tilt the II caudal. And this will be a pelvic inlet view. This is very helpful to look at the anteroposterior portion and to make sure that if you're going to miss on this, you miss high and inside. It's like a brushback pitch from Nolan Ryan. That's what hurts you. And this is right in the center. If you can pull that a little bit towards you, I want to give you an idea about what a good pelvic inlet view is. The anterior rim of the pelvis is very crisp, and the sacrum is kind of a bow tie shape, with the sacral ala being the lateral portions of the bow tie, the sacral body being the center knot. And so that's right in the middle, and we have a crisp anterior border, that's where the lumbosacral junction will run. So we'll go from there to the pelvic outlet view, and we're going to place the implant on the pelvic outlet view. So we're right in the middle. We're not too far anterior. We're not too far posterior. As you can see, you have a nice swath of territory, a large amount of territory that you have to go through. And remember, the vestigial disc was the marker of the S1 neural foramina and the S1 nerve root coming out. So we're right halfway between the top part of the sacrum and the S1 neural foramen. So picture, we crossed into the sacral ala. I'm going to take this and put the Steinmann pin through this. This is an 8-gauge non-tapered jamshidi needle picture. And this is about the depth that we'll put the screw at about the 11 o'clock position relative to the S1 neural foramina. So I'm going to take our rigid access out. And keep in mind, this is a bony corridor. We're not too far anteriorly. We're not violating anything in the pelvis, including the lumbosacral trunk. We're not too far posteriorly, getting into the spinal canal. We have that wide swath of territory that we're going through that is the S1 bone corridor. So I can actually come out on the other side and not hurt anything. Picture, and I'm going to back up the Steinmann pin a bit. Picture, there we go. That's about a 55 right there. I'm looking on the proximal portion of this. This has numbers, and the end of the Steinmann pin registers the number of the size of the implant I need to place. So that's dilator 1. This is dilator 2. These have soft tissue threads. This is designed to be turned in like this through the soft tissue, these large threads. So it's a righty-tighty in through the soft tissue using a clockwise turn. And then I'm going to place the extender pin, and this is a reverse thread. So if we use power, it doesn't unthread it. And then the working channel, this is the working channel. It has a Francine end that goes up against the bone, and this goes over the first 2 dilators. And so this will go over the whole apparatus here and all the way down to bone. We're going to take the other 2, dilator 1, dilator 2 out. And this is very similar to most things. This is a dilation process. So once we get it here, we're going to put our drill, which is 9 millimeters, in preparation for our 11.5 millimeter implant. And this drill will go in over the end of this. So 9.5 millimeter drill in preparation for our 11.5 millimeter screw. And then we'll go, this is a ratcheted device. So all the way to the end, and give me an x-ray, please. So we see the drill coming in, and just like most of the time, even when the body is osteoporotic, the SI joints, especially in the scenario picture, SI joint dysfunction can be very sclerotic and very hard, and that's good for fusion. So we will cross the SI joint. You can see the drill crossing over, picture, the SI joint, and into the sacral ala. I can feel it give there, so I know I'm in. Let's take a confirmatory picture for demonstration picture. And then we'll take the drill out, leaving the Steinmann pin in. And then I'm going to place the implant. And the implant is this. It's 11.5 millimeters in diameter. This particular implant is 55 millimeters in length. And it has features it's self-tapping. It's rifled on the inside so it doesn't push the pin forward. It's 3D printed. It's roughened titanium alloy. The differential pitch allows for lagging features of the screw. The oval windows allow for through growth in addition to the on growth from this roughened surface. And this roughened surface has a surface of the nodules here that are about the same distance apart as the cancellous bone. So we'll place this. We'll place it over the Steinmann pin. Picture. And we will start placing it across the ilium, across the joint. Picture. Still have a nice bite. I can feel it going across. Picture. Nice. And we'll put it all the way to the desired endpoint. Picture. Picture. And just a smidge more. Picture. Good. All the way to the endpoint. Now, if you could arc about 15 degrees toward you, we're going to look down the ilium and make sure that the back end aligns with the posterior portion of the ilium. And this is something to be able to make sure that you have it flush. You don't want to countersink it. You don't want to leave it proud. And so you can see the line that is right at the posterior margin of the screw. I'm going to advance it just a little bit. Picture that. So that is flush with the posterior margin of the ilium. And keep in mind, you don't have to worry about the distal throw. We measured the size of the implant, so we know exactly how long that implant is, and it should fit perfectly. And it is in this case, but let's say you missize this and you need to go a little farther. There's a bone corridor there that you know you're not going to hit anything. It's all the way through, and we have it perfectly lined up. So I'm going to disconnect here. I want to come back to that AP outlet view. Just arc back toward me. Everything comes out. We disassemble this. This is a long Steinman pin. This is the inserter. This is a working channel. And we'll come back and we'll take final views of the outlet and the inlet. Very nice. Let's take an inlet view if we could. Very nice. And we'll skip the lateral view just for the purpose of brevity. I'm going to go ahead and we will show you the posterolateral approach. And this is something that is, so let's come back to the outlet view. And then we'll look at it, both of these implants on the lateral view. And I've kind of arbitrarily selected a shorter implant for the posterolateral view to try to get around the lateral implant that's existing already in there. So we'll start out again with the Steinman pin. I've made marks along the picture here, along the top of the S1, kind of mid portion between the S1 framing, and then another mark picture along the border of the SI joint. I'm going to start right at that point, the intersection of those. So we're going to start out here, and this is more dorsal. Picture that. All right, so this is more dorsal, and it's out of the way of the gluteal muscles. This starts more dorsal. It starts just lateral to the PSIS and inferior to it. So you do have a built-in landmark that's pretty good. Picture that. Picture that. Okay, good. And let's go to the inlet view. So you start off in the inlet view, outlet view, go to the inlet view, and we'll make sure and have our orientation. So this is roughly aligned with the end plate of S1, the superior end plate of S1. And we'll get our medial lateral throw here, our angulation for our medial lateral throw, which looks, pretty darn good. I'm going to going to angle it about like that. Picture. And we're coming down, angling right across the joint. Picture that. Good. So I'm going to place Steinman pin and have the same sequence. So Steinman pin goes in. Picture that. Good. Let's go back to the outlet, please. So we'll take the Jamshidi windshield wiper that thing out, pin and pull, don't lose access. We have dilator 1 down to bone, and the bone here is a lot closer to the skin surface than it is on the lateral view because you don't have any gluteal muscles you're going through. Dilator 2, right? And see, we can see the orientation here. This is the S1 posterolateral screw. And then dilator 2, then working channel. I'm going to make my incision just a little bit bigger. All right. And I'm going to make sure, and Doc, you can always use the working channel and hammer on the proximal neck of the working channel. That's designed to do that, just to make sure you're flush with bone. Okay, have these in. I'm going to put my extender on, and I'm going to try to skip the drilling portion of this just for sake of brevity, since we've seen that before, that 9.5 millimeter drill. Let's remove dilator 2, remove dilator 1, keeping in mind you still have to pen the assignment pin so it doesn't come back on you. And again, I've arbitrarily selected somewhat of a abbreviated size of a screw. This is 45, so this is 11.5 by 45, smaller screw because we might have a little bit of dueling implants going on in there. So this goes on like this, and this is made by Genesis. Genesis has a dedicated posterolateral implant system that you can use with a nitinol K-wire. That's a very nice addition. So, picture. All right, so you can see this getting right across the SI joint. And again, we'll try this without. Picture that. Good. Starting to go across the joint, and let's go back to the inlet view, if you can, please. Go back to the inlet view. We want to make sure the pin is not migrating on us. So there is lumbosacral trunk that runs along the anterior portion of the sacral ala that we need to make sure and not target. So that's a little bit more lateral than our distal tip of the screw. And it's right along the anterior margin, which we are really not aiming at, but sometimes in some pelvies, you'll have a posterolateral screw that aims toward the trunk, and you just need to make sure not have that pin advance on the picture, and not have the screw be too long, which is just a technical error because we will have measured the size of this picture. And so let's arc 15 degrees toward you. I'm going to stop short of that. You can see why I sized this, because this would run into the other laterally placed implant. But otherwise, we'd have a longer screw picture. But what you want to have is a situation like this, and this is a contralateral pelvic inlet view. This is a really nice view. So we're right at the posterior margin of the ilium. Ideally, we'd want the screw to come to the end of the Steinman pin, and it's, I've stopped short because of the obstruction, but that's where the appropriately sized screw. So in this case, a 55, perhaps a 60 millimeter screw would be appropriate, but that's the posterolateral technique. And you can see here how the proximal and distal threaded parts of that screw are bridging the SI joint, and the non-threaded portion lies over the SI joint. So lateral based, posterolateral access, and this is using the Genesis system. Genesis has a separate system for a posterolateral approach with a more conical screw, but it just for the sake of brevity, and because we have this system available to us today, this can also be used posterolaterally. So this is two good techniques, and they're almost interchangeable. I know I do primarily lateral-based fusions. There are many people that like the posterolateral approach because you spare the gluteal muscles, but either one is just fine. So with that, let's open it up to questions.
So I'll ask one. How many diagnostic either procedures or injections are you doing before jumping into the fusion?
So most of the, let's take like the NAS guidelines, for example. So they'll recommend two, one diagnostic and one therapeutic before you do an implant, before you go on to the fusion. So typically I'll do one, and that's how, one looking for 75% relief. I'll only do two if insurance requires it. There's some Medicare MACs that require two injections. NAS criteria for meeting criteria for SI joint fusion requires a diagnostic and a therapeutic. So oftentimes you'll find yourself doing two regardless. I mean, my typical approach and what I think is ideal is I'll do one injection that's diagnostic and therapeutic, mix triamcinolone, for example, and with bupivacaine. They get 75% more pain relief. Then yes, they pass the minimum barrier necessary to move forward. If the injection lasts 4 to 6 months or more, I'll repeat it, doing 2, maybe 3 injections a year. If it lasts less than that, ideally, I think we should go on to SI joint radiofrequency rhizotomy, but that was not stopped being paid for by Medicare about 2 to 3 years ago. And so that's a difficult challenge, because the majority of these that I see with SI joint dysfunction will be Medicare patients. If they do, the insurance does pay for SI joint RF, then we'll go ahead and do that. And then when they fail that, we'll go ahead and go on to SI fusion. Typically, SI joint RF, depending on what you use, will last a year, plus or minus 6 months. But you can go on to fusion if it becomes, pain goes away, it comes back, goes away, it comes back. You can go ahead and go on to fusion. And non-surgical management, or so-called conservative care, is just not very effective for SI joint dysfunction pain.
Is this primarily a technique for people who are post-lumbosacral fusion, or also like just de novo SI joint dysfunction, no history of previous history?
Can you repeat
He's asking if this is primarily done on patients who are post-lumbosacral fusion or just de novo SI joint dysfunction?
Yeah, no, there's got to be a reason. So somebody comes in and they haven't had surgery, they're male, they're younger, and they have SI joint pain. That doesn't happen, really. I mean, of course it does, but that's very, very unusual. So the 3 scenarios is somebody with a lumbosacral junction fusion or long segment fusion across 5-1, female with postpartum pelvic instability, and believe me, this can be chronic. I've seen women in their 80s that have had this for 40 years plus and unrecognized. And then the other category is seropositive and seronegative spinal arthropathies, rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, something like it. And this is, they have to have a reason to have SI joint pain. And typically for the seronegative spinal arthropathies, I do not recommend an SI fusion, because the natural course of this, think ankylosing spondylitis, it's going to go ahead and fuse anyway. Psoriatic arthritis, same. Reiter's, same. Intrahepatic arthropathy, there's a bunch of them. But I tend not to go ahead and fuse in that scenario. Just wait to see what they'll happen. Treat them with DMARD if necessary. Don't if it's not necessary, and then wait for the joint to fuse.
Questions? Yep.
Is there any preference whether do it lateral or the posterior approach?
There's a little bit of biomechanical benefit to going lateral as compared with posterolateral, but the biomechanical papers, to be really frank with everyone here, is based on a single posterolateral implant as compared with either a posterior implant, a very vigorous one that we're about ready to see that Dr. David is going to demonstrate, or 3 lateral implants. And so that biomechanical data may or may not be true. I never just put 1 implant in. I always use 3 implants laterally or 3 implants posterolaterally. Most practitioners just do 2 implants posterolaterally. But most of the data, the level 1 data that we have, is all lateral implants. So we just completed trials using the Genesis. It's a prospective multi-center clinical follow-up trial, registry type trial measuring PROs, and really good pain and functional improvements. Every single practitioner who participated in this was interventional pain or interventional radiology. The other trial that we just finished is called the Stacy trial by SI bone using laterally placed torque screws. And so most of the data that we have is based on the lateral approach. I think the posterolateral approach is good. I think it is supported by the data that we have. I think also the lateral approach is good and supported by the data that we have. But it's just, I prefer the lateral just based on more biomechanical and clinical outcomes data.
Have you ever used the SI bone intra-X or heard of that? Any thoughts on it?
Have you heard of or used the SI bone intraflex?
Say again.
The SI bone intra-X.
Oh, intra-X, yeah. So intra-X, you have intra and then intra-X. Intra-X is the smaller device. So you put on, so can you take a shot for me again? So this is the contralateral pelvic inlet view. And I've taken the lateral, posterolateral implant out. You can see at the very bottom of that, that is the SI joint. And the SI joint, if we were to go a little bit, can you arc about 5 degrees toward me? The posterior inferior portion of that is more antero-posteriorly oriented than the, so you start to sharpen that up. And as you sharpen that joint up, the intra-X is placed right on the pelvic inlet view. It's placed right into the joint on the pelvic inlet view. And you see the more medial part, that's the part of the joint that's more posterior toward us. The more ventral part starts to become more oblique as it goes ventrally. And this one is more antero-posteriorly as it is the dorsal part. So by using this is exactly the approach that you would use. 5 degrees off midline, and the intra-X are little small implants. Put a couple of implants in there. They're made out of cortical bone, and it goes right into the joint. I think that's ideal for very low demand, maybe elderly patient, maybe an in-office procedure is really ideal for that.